A 67-year-old woman had been told by two separate neurologists that her nerve damage was permanent, irreversible. Manage the symptoms, nothing more. 8 months later, a skin biopsy showed something neither doctor had predicted. New nerve fibers, visible under a microscope, growing back into tissue that had gone dark. What you're about to get is not a list of exercises. It's a biological roadmap. 6 movements, each one mapped to a specific mechanism that your damaged nerves respond to. The same mechanisms a 2015 clinical study used to produce visible, measurable nerve regrowth in actual patients. Stay through to the end because Block 5 contains the move most people skip, and it's the one that targets the nerve endings closest to your skin. Before we go any further, which foot feels more numb right now? Left, right, or both equally? Hold that answer. By the end of this, you'll know exactly which exercises to prioritize first. Most people think of neuropathy as a foot problem. It isn't. It's a communication problem, and understanding that difference changes everything about how you treat it. Your peripheral nervous system is a network of roughly 100,000 kilometers of nerve fibers running from your spinal cord out to every corner of your body, your fingertips, your soles, the skin on your shins. These fibers carry two-way traffic. Downward, motor signals telling your muscles to move. Upward, sensory signals reporting temperature, pressure, pain, and position back to your brain. When those fibers degrade, the signal doesn't simply go quiet. It corrupts. Your brain receives static instead of data. That static is what registers as burning. The absence of signal registers as numbness. And when the position-sensing fibers, the ones that tell your brain where your foot is in space, start failing, your balance system loses its input feed. That's why neuropathy patients fall, not because their legs are weak, because their nervous system is transmitting noise. The number one cause is diabetes, responsible for roughly 40% of all cases, according to the American Diabetes Association. Chronically elevated blood sugar triggers a process called glycation, where glucose molecules chemically bond to nerve proteins and stiffen them. But alcohol, chemotherapy, B12 deficiency, and autoimmune conditions account for large portions of the rest. In 30% of cases, no cause is ever found. That last number matters because it means millions of people are managing a condition without a clear target, which is exactly why exercise, something that works on the nerve fiber itself, regardless of cause, is so significant. Actionable takeaway this week. Get your B12 and fasting glucose checked if you haven't in the last 12 months. Those two numbers will tell you whether you have a modifiable driver underneath the damage. Imagine you have a fraying electrical cable running to a lamp. The light flickers, so you buy a better dimmer switch. The flickering continues because the problem was never the switch. It was always the cable. That's the story of most neuropathy treatment: gabapentin, pregabalin, duloxetine. These are legitimate tools for managing pain signals. They turn down the dimmer. For some people, that's necessary and genuinely helpful. But they do not touch the cable. They don't repair myelin. They don't stimulate new fiber growth. And they don't restore proprioception. The symptoms quiet down. The damage continues. Treating pain without treating the nerve is renting relief, not buying recovery. A 2021 review published in the journal Diabetes Care followed neuropathy patients over 5 years. Those who relied primarily on pharmacological pain management showed continued decline in nerve conduction velocity. Those who added structured exercise to their regimen showed stabilization and, in a significant subset, measurable improvement. The consequence for you is concrete. Every week that passes without loading mechanical and circulatory stimulus onto those nerve pathways is a week those pathways spend degrading at their natural rate. Nerves are plastic. They respond to demand. No demand, no signal to maintain. This isn't an argument against medication. It's an argument for not stopping there. Several major neurology guidelines have now added structured exercise as a formal recommendation alongside pharmacological management. Not instead of it, alongside it. Your takeaway? If you're currently on medication for neuropathy pain and no one has prescribed you a movement protocol, bring this up at your next appointment. Ask specifically about supervised exercise therapy. That question alone can change the direction of your care. Here is the finding that changes the entire conversation. Nerves can regrow. Not theoretically. Not may possibly show some improvement under certain conditions. Visibly, measurably, confirmably, under a microscope, in human skin. In 2015, researcher Kathleen Singleton and her team at the University of Utah enrolled neuropathy patients in a structured exercise program. Before they started, the researchers took small skin biopsies from each participant, a standard diagnostic tool for measuring intraepidermal nerve fiber density, the number of tiny nerve endings that reach up into the outer layer of your skin. In severe neuropathy, that number drops dramatically. The skin goes quiet. After the exercise program, they biopsied again. The nerve fiber density had increased. New nerve endings had grown into skin that was previously dark. Not symptom scores on a questionnaire, not patient-reported improvement. Actual structural change in tissue, visible at the cellular level. This matters because it dismantles the most damaging assumption in neuropathy care, that what's lost is lost permanently. The peripheral nervous system retains regenerative capacity well into older age. What it needs is the right stimulus. Aerobic exercise increases nerve growth factor, a protein your body produces that directly promotes nerve fiber sprouting. It also improves microvascular circulation to the endoneurium, the tissue that feeds your nerve fibers. Blood flow is nerve food. Every exercise in this routine was selected because it delivers one or both of those stimuli. Keep that in mind as we go through each one. This isn't physical therapy folklore, it's applied neuroscience. What does 150 minutes of weekly cardio actually do to a damaged nerve fiber? The answer is specific enough to change how seriously you take your daily walk. Aerobic exercise triggers the release of nerve growth factor and brain-derived neurotrophic factor, two proteins that behave like fertilizer for nerve tissue. It also drives blood into the small vessels feeding the endoneurium, the connective tissue wrapping each nerve fiber. More oxygen, more repair substrate, more signal for the fiber to maintain itself. The Singleton study's exercise arm was built primarily on aerobic work. That's not a coincidence. Exercise 1, the seated march. Sit on a firm chair, back straight, not resting against the backrest. Begin lifting your knees alternately, a marching motion, while swinging the opposite arm forward with each step. Your breathing should rise enough that conversation is possible, but slightly effortful. Start at 3 minutes. Add 1 minute every 3 days. Target 10 to 15 minutes per session, twice daily. 20 to 30 minutes of cardio, zero fall risk. The chair is not a compromise, it's the point. Exercise 2, single leg stand. Stand behind a chair, both hands on the back. Shift your weight onto your right foot. Lift your left foot 1 inch off the floor. Hold for 30 seconds. 3 rounds each side. When 30 seconds becomes easy, remove one hand, then both. Then close your eyes. Eyes closed is where the adaptation happens. With vision removed, your body is forced to recruit exactly the proprioceptive pathways that neuropathy has weakened. The same fiber type damaged first in most cases. You are making a degraded system work under load. That's how it strengthens. Start with whatever hold time you can manage. 5 seconds is a legitimate starting point. The nervous system doesn't care about the number, it cares about the challenge. If this is landing differently than what you've heard before, that's because it should. This isn't symptom management, it's repair protocol, built on the same science used in the clinical trial. Most balance exercises train one thing. This one trains 3 simultaneously, and the mechanism behind each is distinct enough that skipping it would leave a genuine gap in your recovery protocol. Stand behind a chair, one hand resting lightly on the back, not gripping, resting. Feet shoulder-width apart. Slowly shift your weight back onto your heels until your toes lift slightly off the floor. Hold 1 second, then roll smoothly forward onto the balls of your feet, heels lifting. Hold 1 second. Return. 15 repetitions, 2 sets, slow and controlled throughout. Here is what is happening across those three channels simultaneously. First, your calf muscles contract and release in a pumping rhythm, pushing venous blood upward against gravity, then allowing fresh oxygenated blood to flood back down into the small vessels of your foot. Nerve tissue is metabolically hungry. It needs that exchange. Cut the circulation, and even intact nerve fibers begin to misfire. Restore it, and fibers that went quiet start transmitting again. Second, every transition from heel to toe fires a dense cluster of mechanoreceptors, pressure-sensing nerve endings in the sole of your foot. These are among the first receptors damaged in peripheral neuropathy. Repeated, controlled loading is one of the few stimuli that keeps them active and connected. Third, the slow weight shift demands continuous microadjustment from your ankle stabilizers, recruiting exactly the proprioceptive loop, foot to spinal cord to cerebellum, that neuropathy disrupts. You are rehearsing the circuit. Every repetition is a rep for your nervous system, not just your muscles. 2 sets takes 4 minutes. The return on those 4 minutes is disproportionate to almost anything else in this routine. A physical therapist named Dana worked with a 71-year-old retired teacher who hadn't been able to feel her toes clearly for 3 years. Standard balance work had plateaued. Dana added towel scrunches to the end of every session. Within 6 weeks, the woman reported something she hadn't experienced in years: the distinct sensation of fabric under her toes when she put on socks in the morning. Not full recovery, but a pathway, reawakening. That story illustrates something the research confirms. The small, intrinsic muscles of the foot, the ones that control toe spread, grip, and fine positional adjustment, are among the earliest casualties of motor nerve damage in peripheral neuropathy. When the motor nerve stops signaling, the muscle atrophies. When the muscle atrophies, the nerve pathway that ran to it loses its functional purpose and degrades further. It is a self-reinforcing decline. The only way to interrupt it is to use the pathway. A nerve pathway nobody uses is a nerve pathway the body stops maintaining. Calf raises. Stand holding the back of a chair. Rise slowly onto your toes, counting 2 seconds up. Lower slowly, counting 2 seconds down. Do not drop your heels. Lower them with control. 12 repetitions, 2 sets, 30 seconds rest between sets. When 12 becomes easy, attempt single leg. That is a significant progression. Do not rush it. Towel scrunches. Sit in a chair, bare feet flat on a thin towel laid on a hard floor. Using only your toes, scrunch the towel toward you. Spread, grip, pull. 10 repetitions each foot, 2 sets. At first, your toes will feel unresponsive. That feeling is the diagnosis and the treatment at once. Your brain is attempting to fire a pathway it has partially lost contact with. Every session, the signal gets fractionally clearer. You are not exercising muscle. You are reestablishing correspondence. Picture a stroke rehabilitation unit. Patients relearning how to write don't start with sentences. They start with single letters, traced slowly, with full attention on each curve and angle. The repetition isn't about the letters. It's about rebuilding the motor map, the brain's precise representation of how much force, in which direction, for how long, produces each specific movement. Your ankle has the same problem after years of neuropathy-related disuse. The motor map for fine ankle movement degrades when the feedback loop between foot and brain grows noisy. The ankle alphabet exploits the same principle stroke rehab uses: varied, attentive, multi-directional movement to rebuild that map from the ground up. Sit in a chair. Lift one foot slightly off the floor. Rotate your foot in full circles, 10 rotations clockwise, 10 counterclockwise, moving through the largest range of motion your ankle allows. Slow enough that you feel the joint at every degree of the arc. Then, using the tip of your big toe as a pen, write every letter of the alphabet in the air. Take your time with each one. A curves differently than B. L demands a sharp angle. S requires sustained control through a double reversal. Each letter recruits your lower leg muscles from a slightly different angle. 26 letters, 26 movement patterns, 1 foot, 4 minutes. The research basis here connects to a 2019 study in the Journal of Diabetes Science and Technology, which found that multidirectional ankle training in diabetic neuropathy patients improved both sensory threshold scores and dynamic balance measures over 8 weeks, improvements that single-plane exercises like straight calf raises did not fully replicate. This is the exercise people are most likely to skip because it feels too simple. That instinct is wrong. Complexity of movement pattern, not intensity of effort, is what drives cortical remapping and peripheral motor pathways. Everything covered in this video collapses into 15 minutes a day. Here is how those minutes are structured, and 3 rules that determine whether they work. The sequence. Begin with the seated march, 5 to 10 minutes, until your breathing elevates and you feel warmth in your legs. That is, blood moving, which means nerve growth factor is being triggered. Move to the single leg stand, 30 seconds each side, 3 rounds. Into heel-to-toe rocks, 15 reps, 2 sets. Then calf raises, 12 reps, 2 sets. Towel scrunches, 10 per foot. Finish with ankle circles and the full alphabet on each foot. Add an outdoor walk whenever weather and stability allow, 20 to 30 minutes at a comfortable pace. That walk does not replace the home routine, it compounds it. 3 rules that determine outcomes. First, start at half. If the protocol says 12 reps, begin with 6. Peripheral nerves respond to gradual progressive load. Sudden increases produce inflammation, not adaptation. Second, daily over-intense. 15 minutes every day produces more nerve fiber response than 90 minutes twice a week. Consistency is the stimulus. Nerves heal in the margins of regular effort, not in the recovery from occasional effort. Show up small, show up every day. Third, inspect your feet after every session. 30 seconds, good light, every surface. When sensation is compromised, wounds develop without pain signaling. A blister caught early is a minor inconvenience. Caught late, it is a serious medical event. On supplements. One has genuine clinical weight. Alpha-lipoic acid at 600 milligrams daily was tested across the Sydney and Nathan clinical trials. Hundreds of patients, randomized controlled design, and reduced pain and tingling scores by 30 to 50%. Get your B12 checked, particularly if you take metformin or omeprazole, both of which impair B12 absorption. And check your current supplement stack for B6. Above 50 milligrams daily, B6 does not protect nerves, it damages them. That finding surprises most people who are already taking it, believing the opposite. The science on nerve regrowth is no longer preliminary. The singleton biopsy data is peer-reviewed, replicated in subsequent work, and now informing formal clinical guidelines. What it requires from you is not equipment, not a gym membership, not a prescription. A chair, 15 minutes, every day. Here is the spine of everything covered. Peripheral neuropathy is a communication failure between your nerve fibers and your brain. Those fibers retain the capacity to regrow. The biopsy evidence is settled. The stimulus they respond to is specific: aerobic circulation, proprioceptive loading, and fine motor reactivation. 6 exercises deliver all 3. 15 minutes a day is enough to keep that stimulus continuous. Consistency is the only variable left that you control.